you very much to the organizers. They have chose to give the final lecture of the session as an Oscar to the career to the senior surgeon, because, you know, maybe the future is not going to be his, he's not going to see his involvement, but you're wrong. So this is my view of the future, especially minimally invasive thoracic surgery. We all strive to make minimally invasive thoracic surgery better in order to make it easier for the patient, easier for the surgeon, more cost-effective, scientifically sound, reproducible, and I will come back to this, and make it, in order to make it stand the test of time. Obviously, we can make a lot of, you know, research, clinical, preclinical, experimental, translational. Let's look at what's new. And I'll tell you later that I'm going to anticipate a little bit of a twist at the end, because I think we should not worry too much about what's new, but what we have. So, of course, we can look at ergonometry and 3D visualization, efficacy and safety of energy device, like Steve was alluding to, microstaplers, hybrid ORs, robotic, UniVATS, notes, and all the strategies for perioperative management, like the awake and non-intubated. But I think we need to focus on something different. So localization, hybrid ORs, we all know what they are, and they're going to help us in localizing nodules and performing lobectomies in the same theater. The innovations that we have are especially on the visualization modalities. We can use wide-angled rigid and flexible scopes with reticulating tips, and are now already available, or the so-called mags, that micro cameras that are moved from outside the chest with magnets. Or we can use this wireless steerable soft endoscope. They can be kind of modeled and shaped according to the structure of the chest that you can obtain through 3D reconstruction. And you can put more of them, more than one, so that you can have a visualization from different angles. So you make your surgery safer. We already heard about vessel closure. I'm not going to go further on that. Ergonometry is an issue because, of course, some sort of VATS approaches may entail more postural difficulty compared to others. But what is really making the difference, it will make a difference, is the nanotechnology in the future. We know that nanotechnology is already being used for imaging and some therapeutic purposes. We're going to have magnetically powered micro-robots, and maybe they're going to do the job for us before we intervene with the VATS. Or we can collaborate with biomolecular biologists in order to affect genome editing on specimen removed from the patients, like lymph node biopsies or tumor biopsies, and then through genome editing reconstructed and re-injected in the patient in the same site or through the blood or intratracheally. This is a work, by the way, done by a thoracic surgeon in Stanford. But let me tell you what is important, and it has a practical relevance to us. How many times we do not know the diagnosis of a nodule that we want to do we think and we suppose with all our algorithms that is malignant, but we do not have the diagnosis. So how many times that happen? And according to the literature, that leads to VATS lobectomy done for benign lesions in almost 10% of the patients. So an alternative is try to find out whether exhalate breath analysis can take us to the target, to try to define whether we have a malignant lesion that we have to remove. And this is based on classic studies on volatile organic compounds. There are chemical structures that you can find in a patient's breath, individual's breath. And you can do two things with breath analysis. One, give basically a quantitative definition, so you can count how many of these chemical compounds are in the exhalate and correlate them to the disease. And to show you that this is not science fiction, it's been done, and you see the difference in the graphs between the headspace gas that is removed from cultures of a commercially available cells, adenocarcinoma cells, like A549, compared to normal tissue and blank medium. Or, with the same exhalate, with the same compounds, you can look for pattern recognition, try to see whether a pattern of distribution of the chemical compounds can be related to the disease. And you can do it through using these electrodes that can be connected to even biological, taken from canine specimen, olfactory receptors. And through carbon nanotubes, these stimuli are conducted and translated into this. Signals that are correlated mathematically and create a sort of these radar charts that are exactly like music. So if you find this bit that is related to a melody, and this bit that correlates to the same melody, you can figure out what is the song. And that's exactly what's happening now with breath analysis and pattern recognition. But this is not what is important, in my opinion. What is important is what we are trying to understand right now, and this is the future, although is an evolving future while we speak. We need to understand what will be the results of two major trials to find out whether sublobar resection can be the new black for the future. We need to understand the merit of VATS compared to open. And this is especially important because, like I said in the beginning, reproducibility is an issue. Why would reproducibility be an issue? This is a paper that was published last year. And basically found out that in Great Britain, and in the UK and in the States, the percentage of lobectomy done by VATS is 30%. With a huge variation. And a variation that is due to limited personnel, to lack of expertise, or surgeon preference. And in order to reduce this variation, of course, we need new training techniques and learning opportunities. So we can define VATS training pathway because, of course, if 30% only of the lobectomies are done by VATS, that means that not many of us do it. So we can define how to go through lecture format courses. We can do courses with assessment scores. We can have mentorship after the wet lab. We can have committees reviewing clinical practice in a subsequent order of magnitude in terms of importance. But the real thing is what I've written here. The percentage of surgeons performing VATS lobectomy varies with the geographic areas generating the database. It is higher where surgeons are relatively younger, where hands-on VATS starts early in training, where the competition for patients is fiercer, where a provision of surgical care is centralized, where lung cancer screening programs are active. And it looks like VATS lobectomy is a procedure for young surgeons. What happens to the senior surgeons? The ones who can maybe get from 30% to 50%. Well, you know, there are lecture format courses that all of us go, our senior surgeons. We use it in learning. We use trial and error on patients. But what I would like to propose, and we're already doing this in Italy through the so-called VATS group, is the self-assessment. Senior surgeons are difficult. They will not recognize their limits. And maybe the best way would be for them to look inside of their own practice without having any kind of interference from external sources, giving them performance targets and see whether they can proceed and improve month by month. So what has been done in Italy, the VATS group, 100 centers have created a possibility for senior surgeons to go through this method and to rate their performance. They have to rate themselves, their own performance. By rating the performance at the end, you're going to have a number which is relates to a ruler that is going to give you exactly where you stand, and what do you need to improve if you need to improve. So this project is called the VATS project. Very experienced, time-honored surgeons for VATS lobectomy, and this is the only way right now I see a future for our specialty. So the future of MITS, VATS and robotic is connected to technological refinements along the lines of micro and nanoscale. The reproducibility is still an issue, and training credentialing is the solution. The necessary resources need to be allocated to retrieve senior surgeons to minimally invasive thoracic surgery. Thank you very much.